So for those of you who don't know me, I'm Kim Lewis. I am an intensivist at St. Joe's and clinical scholar at McMaster. And today I'll be talking to you about my systematic review and meta-analysis called Safety and Efficacy of Dexmedetomidine. You're really close, it's a long one, in acutely ill adults requiring non-invasive ventilation. So a little bit of background. Lots of big words there. Non-invasive ventilation is a respiratory support machine. And what it is, it's a mask that sits very, very tightly to a patient's face. And that allows us to give very high pressures and high amounts of oxygen to the patient that's having a respiratory problem. This is different from invasive mechanical ventilation and intubation, as there's an endotracheal tube or a breathing tube that bypasses the upper airway, and the end of the tube inserts directly into the trachea, which leads into the lungs. In the latter, patients also have to be completely sedated, usually in a coma, to tolerate this. Non-invasive ventilation is a life-saving intervention for many causes of respiratory failure. And as you can probably imagine, compared to invasive mechanical ventilation, it's associated with a lower risk of mortality, less pneumonia, a shorter ICU length of stay. It's cheaper for the healthcare system, and understandably, usually preferred by patients. Unfortunately, if you can imagine a giant tight mask being suctioned to your face, jamming high pressure air at you, it's going to be uncomfortable, and it is uncomfortable. And in fact, a third of patients will become agitated or delirious just by virtue of having this mask on. Ideally, a sedative could improve tolerance by relaxing the patient. However, all of the classic sedatives that we have to date that are commonly used in ICU can cause a very deep, profound sedation. And this could result in central apnea or the patient not breathing. Think about Michael Jackson and propofol. It's a prime example. So really, this leaves physicians often with no choice but to intubate and mechanically ventilate the patient. Except there's a new kid on the block called dexmedetomidine, and it's a new medication with expanding clinical uses, and it may be our solution. It's an alpha-2 adrenergic agonist, and it's characterized by providing awake sedation. So what that means is you're fully aware of everything that's happening, but you kind of just don't care. I actually had a friend that had to have a breathing tube put in. They placed him on this, and they said he knew everything was happening, remembered everything, but just couldn't care less about what was actually going on. So it doesn't impact your respiratory drive at all because it doesn't really put you to sleep. It provides very important analgesic effects and can actually prevent and treat delirium. Therefore, we hypothesize that dexmedetomidine versus any other sedation strategy or placebo in adults that are admitted to the ICU with respiratory problems being treated with that non-invasive ventilation machine may result in a reduced need for intubation, less delirium, and a shorter ICU length of stay. So how we did this, we did a systematic review. We included RCTs. We excluded pseudo-randomized or quasi-randomized RCTs. We included RCTs that had included adults that were 18 years of age or older admitted to the ICU with respiratory failure and were being supported with that non-invasive ventilation machine. The intervention was dexmedetomidine at any dose, initiation day, route, frequency, and for any duration of time. The comparison was any other sedative. So an opioid, a benzodiazepine, propofol, an antipsychotic, it didn't matter, or placebo. And the outcomes that we were looking for was need to be, NIV failure, need to be intubated, delirium, mortality, ICU length of stay, and a host of adverse events. To do this, we searched MBASE, Medline, Cochrane, and trial registries. We went from inception to July 31st, 2020. Screening, full text, data collection, risk of bias 2, and grading was done independently and in duplicate. And this is what we found. So after duplicates were removed, we had 1,388 studies After going through after going through abstract and title, we excluded 1,361 trials. This left us with 27 that were eligible for full text. After going through the full text, we were left with 12 RCTs that included 738 patients. The mean age was 61.5 years. 36% were women with a mean Apache 2 score, which is how sick a patient is, of 19, which is pretty normal for your average run-of-the-mill ICU patient. 6 trials compared dexmedetomidine to placebo, 2 to Haldol, 3 to a benzodiazepine, 1 to propofol, and 1 to just usual care. So whatever the treating team wanted to use, they could. So what we found here is that dexmedetomidine reduces the risk of needing to have endotracheal intubation and invasive mechanical ventilation. Our point estimate was 0.54, which is pretty impressive, with a 95% confidence interval anywhere from 0.41 to 0.71. We had an I-square of 0. This left us with moderate certainty, and we rated down simply because of risk of bias. A lot of these didn't describe how they randomized patients, unfortunately, so we downgraded for selection bias. In a subgroup of intubation, we looked at dexmedetomidine compared to each of the individual comparator agents, so placebo, benzodiazepines, Haldol, or sedation as per treating team. And as you can see, there was no significant subgroup effect causing an effect modification depending upon the different treating agent. Another subgroup we did was looking at whether or not the patients were delirium at the time of initiation of enrollment into the RCT. And again, there was no subgroup effect that we were able to see. P was 0.26. That's an excellent segue to the next outcome we looked at, which was delirium. And we found, again, that dexmedetomidine does reduce the risk of delirium. Quite impressively, 0.34 was our point estimate, 0% I-squared, and this was a moderate certainty, again, downgraded for the risk of bias. We then looked at mortality at longest follow-up. And not surprisingly, we found that dexmedetomidine did not change your risk of mortality, as our 95% confidence interval did cross 1. And this was, again, downgraded for risk of bias. Other outcomes that we looked at, so we found that dexmedetomidine did reduce ICU length of stay by a mean difference of 2 days. This was a low certainty of evidence. I-squared was 83. It did also reduce the risk of pneumonia quite significantly, and this was a moderate certainty of evidence. I-squared was 0. 2 of the well-known side effects of dexmedetomidine is it causes your heart rate to drop, so bradycardia, and causes your blood pressure to drop, hypotension. And not surprisingly, we found that there was an increased risk of both of those, bradycardia and hypotension, in patients that were given dexmedetomidine compared to any other sedative. However, interestingly, there was no need for intervention. And by intervention, we meant doing anything other than just dose reducing the dexmedetomidine. So there was no increased need to do an intervention like start an inotrope or vasopressor or pace a patient, for example. So really, they needed nothing more than just a dose reduction if those complications occurred, maybe. Other things that we looked at, so we did 2 sensitivity analyses, one by risk of bias, and found no difference. And we also did a post hoc analysis where we excluded abstracts. Again, there was no difference in any of our outcomes. So in conclusion, although non-invasive ventilation is a life-saving intervention, its true therapeutic potential can be diminished because of patient discomfort and non-compliance. So in our systematic review and analysis, we found that dexmedetomidine reduced the risk of intubation, reduced the chance of delirium, shortened the ICU length of stay, reduced the risk of pneumonia, had no effect on mortality. There was a small risk of hypotension and bradycardia, though, with dexmedetomidine, which is expected. So the strengths of our meta-analysis. This was the very first systematic review of meta-analysis on this topic that we were able to find. We underwent quite rigorous methodology. So everything was done in duplicate. We searched many different databases. We involved experts in the field and that had done, the primary RCTs and made sure that we weren't missing anything. The limitations on this is that there's just really little primary research that exists. Many of those trials were pilot trials with anywhere from 20 to 100 patients a pop. And so there was only the 700 patients in total. And this really did limit, I think, the subgroup analyses. So there was no difference in those subgroups I showed you, but maybe there just wasn't enough patients to power it. Our findings were also tempered by a high risk of bias. So we think future trials are needed to improve the precision of the estimates, explore dosing because it didn't really look at high versus low dosing of dexmedetomidine, and potentially to see if there's any effect modification of the subgroups. In WOX, so from this, which is fun, we're doing a research program called INDEX, so non-invasive ventilation in dexmedetomidine in critically ill adults. And this is our plan. So I saw Dr. Iorio online. We were just given a HASL grant to start the pilot trial, which is really exciting, and that's well underway. We're sending a survey of practice to see what intensivists are doing right now for sedation. We've obviously completed the systematic review, and we've applied for REB for a retrospective cohort study. And once that's done, our plan is to do an international multi-centered RCT that will ultimately update our systematic review and analysis, create a practice guideline, and go from there. So just a quick thank you to the co-investigators and collaborators, Josh Pitikaru, Dipayan Chaudhuri, my mentor, Waleed Alazani, and then Eddie Fan, John Devlin, John Besmaji, and Morton Highlander. I welcome any questions or comments.